Welcome everyone to this webinar from the Mental Health Services Learning Network of Australia and New Zealand, better known as THEMHS. And kia ora to people joining us from New Zealand. I'm Kath Chapman, Board Chair of THEMHS. Before we start this evening's webinar, I'd like to begin by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea and community. I'm joining you today from Gadigal land in New South Wales, and I pay my respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people present today. I would also like to acknowledge the many people with lived experience of mental ill health. We recognise their stories and experiences and value the courage of those who share their journeys for the purpose of learning and growing together. Now, the topic of tonight's webinar is Seeking Connection, what is really happening on the front line of mental health system support. And it was chosen after the recent publication of GP Adrian Plaskett's truth-telling article about Australia's mental health system. So this constructive conversation is an opportunity to examine why our current system isn't working. And more importantly, we'll focus on exploring possible solutions and a better outcome for those seeking and those providing help. And in true THEMHS tradition, we bring together different perspectives with the purpose of building collective understanding and ultimately better working together. Now, THEMHS recognises that discussing mental health issues can be confronting, and we recognise that at present many people are in particularly difficult circumstances. So if at any time you are feeling distressed, please do seek support. In Australia, you can call Lifeline on 131114 or Beyond Blue on 1300 22 4636. And in New Zealand, you can call or text 1737. And there are, of course, many other wonderful support services that you can call on. So welcome. I'll now hand you over to Natasha and to the panel.
Thank you so much, Kat. And I think I can be seen. Yes, I can. Great. Thanks so much, Kath. I'm so delighted to be here. And again, from my kitchen table. I guess many of you are joining us from your kitchen table too. I'd like to acknowledge that I'm joining you from a kitchen table on the lands of the Wurundjeri, Woiwurrung and Bunurong peoples of the Kulin Nation. I want to also acknowledge Aboriginal and Torres Strait Islander and Maori leadership in caring for people's mental health, in caring for country, because as we know, those things are intimately linked, aren't they? And wherever you are, I guess I also hope you are finding small ways to be tender with yourself right now. You know, this is a very strange time, the strangest that we possibly will ever experience in our lives. It's an historic time, and I hope you're finding little things that help you feel less frightened and less anxious, less alone, less isolated. It really is a time for living in the moment, isn't it? I'd really like to think of today's hour that we have together as a kind of virtual kitchen table. Conversations happen at kitchen tables. Really frank conversations happen at kitchen tables, don't they? We have three special guests to kick off the conversation, but we absolutely want your questions pouring into the portal that you can see in front of you. So you'll use the Q&A, live Q&A function to do that. I can see some of you are already posting. You can use your full name, your first name, or a pseudonym, whatever you're comfortable doing. But whether you're a service user, someone with lived experience of mental illness or mental ill health, whether you are a friend or a relative or a carer of someone who seeks support for mental illness, whether you are a GP, whether you run or plan mental health services, I want to hear from you tonight in that portal. So do not hold back. I want your questions. I want your comments. We are all of us on the panel tonight really want to weave in your voices as early as possible. And that's going to be my job, right? So I'm going to be looking to this screen, actively listening to everyone on the screen, but I'm also going to be looking to you, the assembled hundreds of you, and your questions. So if I'm looking distracted, I'm not looking at the puppy over to my right. I'm actually looking at the screen and at your input. So to help us focus on the front line of mental health support, what needs to work better, we have three wonderful speakers joining us. Grace McLaughlin. And Grace, you know, as we were talking, I forgot to check the pronunciation of your name. So help me.
Grace McLaughlin.
McLaughlin, yes, thanks for that. Grace McLaughlin has been involved in peer research with Mind Australia and Nemi National. Actually, she's been a co-author recently on a very interesting journal article focused on telehealth and how it's being used right now in the COVID-19 pandemic, looking at the perspectives of users and of health workers. Grace is super passionate, I know this, about the inclusion of lived experiences and perspectives across the mental health system and in mental health services. She has her own experience of living with the effects of complex trauma and with navigating our mental health system from her teens, as many of you joining tonight do as well. So we look forward to the lived experience voice strong in this conversation. Dr. Adrienne Platt, thanks so much for being with us, Grace. Dr. Adrienne Plaskett is a semi-retired, I think, GP who has worked in Newcastle and the Hunter Valley, the beautiful Hunter Valley, for the last 30 years. That's where my mum is right now and has been for about the same time. I discovered he also has a podcast called Soothing Science, which he creates alongside his many other passions like bushwalking, and that's one of his photos behind him tonight. And a recent article, as Kath mentioned, in Guardian Australia, lamenting as a GP the lack of accessible and affordable and available and equitable mental health services in the community is really a prompt for tonight's discussion. So we're going to unpack that article together. Dr. Ruth Vine is joining us. Thanks for joining us, Adrienne. Sorry. And Dr. Ruth Vine is joining us. She's Australia's first Deputy Chief Medical Officer for Mental Health. Fantastic to have you in that role, because I know you are a great activist voice in mental health services as a psychiatrist, as a consultant psychiatrist with more than 25 years experience, including as Deputy Chief Psychiatrist and Director of Mental Health in Victoria. Ruth's been very active in championing policy and action, and particularly now at the federal level in what we need to do to shape Australia's mental health system. Thanks for joining us, Ruth. And unmute yourselves. You can all unmute yourselves now. So let's really go for it. And thanks, your questions are coming in. I can see that. Woohoo! Okay, Adrienne, I want to start with you. You wrote this article. It really struck a chord. And so I want to get your sense as a GP, because you're the first port of call for a lot of us when we're struggling with our mental health. What do you feel? Why do you feel you no longer have a clear pathway to enable your patients, the people that come to you, to get support that they need for mental illness? Something's not working for you, something very fundamental.
Yes, I mean, I write a lot of letters and to politicians and people like that, and I saw that call out in the Guardian, and so I kind of just wrote it as I saw it. I mean, to a certain extent, it could have been about many areas of health, and I think taking a broader perspective, as a GP today, you really have two choices depending on how much money the person has. We've got a two-tier system, and it's quite clear cut that that's the case. And to some extent, I could have written it about orthopedic surgery or in ENT, but I think mental health has always started from a low base and a level of stigma, and then as time has gone on over the last few decades, I've kind of observed that the state health services are no longer as active as they used to be, I think, and there's been this sort of this nudging of the system towards the private. And I guess that's also happening in many other areas of health, whether it be aged care or other things. So yeah, it is frustrating. And the reason I wrote the letter is really because I personally find it upsetting to be part of a system that entrenches inequality. And in the health system, that's what we do. And so it's part of my own sort of sense of well-being to try and do something for a bigger picture. And I kind of didn't expect to end up here just because I
well, it's great.
wrote off a few lines to the Guardian.
It's really great that you did, and Mary has written in the Q&A here. And just to explain, you won't see the Q&A, all those viewing. I see it though, so just type in, and I can assure you that I'm seeing your comments. But Mary writes, fabulous article by Dr. Plaskett. Thank you. It could be anywhere in the country. But let's drill into the detail. So at the moment, you're feeling disempowered as a GP to fully support someone who comes to you with a serious mental health issue. So what support do you feel what support do you feel like you're not able to give that person as they then enter the system, so to speak, to get further support? Because the sense I got from you is that you feel like you can't follow people through. You have a 1-800 number that you can now call to.
Yeah, I mean, I think it all depends on the complexity of the problem and so on. So certainly some people we're quite happy to deal with ourselves. And I guess though, in other areas of medicine, I have this sense that, say someone's got chest pain or whatever, I've got this sense of, I know someone to call and get advice. There's a kind of clear-cut pathway, and there's a sense of shared decision-making and that sort of thing. Whereas if I don't know what to do in, with mental health, it's less clear where to go. At the very severe end, we've got the 1-800 number and, scheduling available to us. But in the middle, if you're trying to get someone into a psychiatrist, it just doesn't happen in Newcastle. You can write a mental health plan and, it's quite a long waiting list and the psychologists are all quite expensive. And so I guess there is no real problem when people have got money, but when they don't, and a lot of places where I work, people don't have money, then it becomes, very, very problematical to work out what to do. So I think that's really, my bugbear would be lack of access for people who don't have the resources to access the private system.
Okay, that's a very important point. And Margaret has written in our Q&A, the frustration regarding the 1-800 number is that it's not working in some areas. And Fee's written, the 1-800 number is not a guarantee of being able to get the person in distress the help they need, a common misnomer. So even at the severe end, the 1-800 number is failing some people. Grace, I want to come to you. You started accessing mental health support and services in your teens in country Victoria. What was it like for you at that time? Did you feel that you were able to access support that made a difference to you at that time?
Yeah, it's interesting. At that time, it was the first time I was accessing mental health support. I don't think I realised that I had some complex mental health problems. I initially just spoke to school councillors. I think I was linked in with Headspace, and eventually a private psychologist, but we didn't really get very far because I think that they were just treating me for just some mild depression, which really wasn't the case. I had a lot more going on than that, and needed a lot more maybe specific or specialized support. So that wasn't, and I don't really think that was available. I don't think that was really available at all in Bendigo, but I wasn't able to access anything for a few years later.
Yeah, and you moved to Melbourne. I know there's a Headspace up in Bendigo because I've had friends who have accessed it, but it's that kind of ongoing follow through, isn't it? That you've finding what you need when you need it. What happened after you moved to Melbourne and hit the big smoke?
Yeah, so I was able to be linked in. Well, actually, it was a really long process. I had some great non-clinical support, which was possibly some of the best support I've had on this whole journey. But I had a long process of trying to link in with some specific clinical support. I remember I was first referred to an eating disorder service to try and get some help there. And there was a bit of a wait period with that, and eventually had a really long assessment. And they said I wasn't eligible for their services. And instead they suggested just a psychologist. So then we put through 2 referrals, one to the community, like the local community mental health team, and one to Headspace. Community mental health team said I wasn't unwell enough for their services, and Headspace said,
wow,
we're an early intervention service, you're not early intervention.
Wow. And so you had to, I mean, I think that Kylie really resonates. She said this earlier in the Q&A, our mental health system is so fractured and often re-traumatizing for consumers. So you were kind of having to reveal all the troubles that you were having, and then being pushed away. Yeah,
so it was like with every referral, there was an assessment where I would have to go through my story and say all of the things that are really hard to talk about, and then be told I didn't fit their service, and then told try this instead, and then sit on a wait list for this, and then do an assessment and be told no. It was quite dehumanizing, to be honest.
Yeah.
And eventually, this went on for 18 months. And I was really, really, really unwell at that point. Like, it wasn't for that non-clinical support I had. I think it was just so bad. I couldn't I'm starting to ramble.
Yeah.
But
no, you're not. You're actually describing so lucidly the experience that I think a lot of people have. And I wonder how you reflect now that you're really actively engaged in as a consumer voice, trying to inform the services that you also utilise, what you think might have made a difference.
Yeah, I've been thinking about this, being like, what actually could have made a difference? I think the big problem is the notorious missing middle. Like, the experience is so common, and that there just aren't enough. There's often a lot of early intervention services, and then a lot of, I don't know how you describe the other end of that. And then you have this missing middle where so many people are falling through the gaps. So I think that's a system failure that needs to be fixed. And I know that's not you can't just click your fingers and that's done. But then I was thinking about what are small things that people can do on an individual level. And I know I was on a wait list for 12 months for something, and there was probably 2 months where the referral just hadn't gone through, and there were dozens and dozens of phone calls from me trying to figure out where the referral was at. So I guess a practical thing that people can do is be on the ball with where referrals are at.
Checking in. Grace, thank you. Thank you so much for describing your experience so far. And you've, as Bradley has written in the Q&A, thank you, Grace. You have showed up the very declining status of psychosocial support. You've described it so beautifully. Thank you. And I'll come back to you again later to I guess get a little bit more detail. But Ruth, you're listening to Adrian and Grace in your role, and also as a psychiatrist, a consultant psychiatrist. And Adrian raised the point about the workforce. So there aren't enough psychiatrists available. The public mental health system is, on the whole, quite inaccessible to a lot of people. And psychologists are terribly expensive. Even if you have a mental health care plan that you do with a GP, there's still a gap payment, and that's expensive. And you only get 6 sessions, maybe with some top-ups. So something's not working here. And in terms of accessing people that you need when you need them. What are your thoughts on that?
So clearly I've got lots of thoughts about that, Natasha, and I'll try not to talk for our full hour. And so just to cut back a little bit, I think. Firstly, thank you, Grace, very much for explaining and sort of illustrating your experience. And Adrian, thanks for putting pen to paper and putting the letter into The Guardian. I think And by the way, I've worked in public psychiatry for the last 30 years. So, I share many of your experiences and your concerns. And I guess there's a couple of things that I'd just say we seem to have got terribly wrong. And one of those is that Australia's population, particularly in some parts of Australia, has grown massively, and yet the funding and the services have not grown in proportion. And, and we see that particularly perhaps in outer metro areas and in some of our cities. Secondly, back in 2006, there was a thing called the National Action Plan, which was led by the then Prime Minister, John Howard. And one of the results of that was the introduction of better access, which was to provide supposedly accessible, affordable psychological interventions. And it was probably a good idea, but as you've highlighted, MBS is a small business. It's a market. So people choose, they don't have to charge a gap fee. People choose to charge a gap fee and choose where they might live and where they might provide services. So although we had a massive increase in the availability across the population, it was not well distributed, as Adrian's highlighted, and not necessarily affordable. And you've highlighted it was capped because everything needs to be rationed a bit, although I would highlight that in the context of COVID, the number of sessions has increased. In the context of bushfires, that happened too. In the context of some specific illnesses, that's happened. But
our access to GPs is not rationed. So why on earth are we rationing our access to mental health care?
I can't answer that except to say that it was to try and make things available, and there's been a massive increase in the number of psychologists delivering those services since better access was introduced. But we live in Australia, and Australia is a federation of states, and I think, and Adrian perhaps highlighted this, there's perhaps no other area of health where that Commonwealth state divide, that MBS state funded divide is as marked and as variable. And to be fair, I think we've recently had a number of reports. The Productivity Commission put down their mental health report in 2020, and the Victorian Royal Commission did an absolutely forensic examination of the Victorian system and released their report. Both of those reports highlighted that we need to build up our services in the community. Adrian in his article touched on a whole range of services like outreach services and availability of treatments for a whole range of types of presentations, including sorts of presentation and problems that Grace has described. So those reports are there, and I think there is a real awareness and willingness on the parts of providers and governments to really think, how can we get a better integrated system? Because we've all heard the problems.
So, but what do you think would be key in getting a better integrated system? We know the problems. How do we stitch it together?
Well,
and Katrina has asked, how will the recommendations of the Royal Commission help to change the experiences Grace has described?
Well, I'll do a quick flip with that. One of the things that the Productivity Commission certainly included, but the Royal Commission really emphasised, was that absolute engagement of those who had experienced seeking treatment and care and support within the mental health system and their carers, and saying that experience needs to be heard and be given a chance to have input all along the way. So I think that's one thing. But I think you've mentioned workforce already, Natasha, and I do think that's critical, and we do need to find ways for people from a whole range of disciplines, not just psychiatry and psychology, but Grace mentioned psychosocial supports as well as allied health, wanting to come and work in a system. And I personally, this is a Ruth Vine view, making sure that we do have at a local or regional level much greater integration and reciprocity between those services that are primarily funded through the state and those services primarily funded through the Commonwealth, and a degree of shared governance almost. And we do see that there's a few good examples of that dotted around, and I think there will be more of it.
Darren has suggested more peer support is key. And then also there was another comment here, and I might not be able to attach the name to it to be quick enough, but when on earth are we going to get registered councillors in the mix too? so that they can also be part of filling the gap?
Well, I mean, I would sort of say here that if you look at the current system, and I'm absolutely not defending it that it's not fragmented, but there are the services that are funded through PHNs, primary health networks, and often they do include counsellors. There are services funded through MBS, like medical psychology, and there are services funded through the state and include. So I actually think that already counsellors are clearly part of the system, both private and through some of the PHN funded ones. And I just, COVID has been a horrible, horrible thing, but COVID has given us some benefits, and I just want to name a couple of those. One is the one that you already mentioned, which is that real shift to telehealth and the availability of telehealth, which Grace wrote about in her article. And I would never say that was the be all and end all, but it has allowed a lot of engagement between clinicians and people seeking help during this COVID pandemic, and we've all got much better at it. Look at us, we do it easily as pie. And the second thing I'd mention is that in the context of COVID and in the recognition that it really was going to have a major impact on mental health and people's sense of their own coping and resilience, several new things happened, and some of those were about improving the capability and availability of pre-existing things, but some of the others were like in Victoria, the development of a sort of pop-up mental health clinic, the Head to Help clinics, and they've just recently been funded in Greater Sydney as well, and they absolutely include peer support workers as well as possibility for counsellors. So I think we've got a long way to go, Natasha. I'm not suggesting we haven't.
We do.
And many pretty high hurdles, but I do think that we do have a way to tackle some of those problems that you've highlighted.
Mary has said, well done, Grace. You're an articulate and intelligent woman. There's a whole lot of love coming in for Grace, so thank you for that.
Well done, Grace.
And a number of questions, which I'll come to you, Grace, on around what exactly was the non-clinical support that you found so helpful. So we might explore that a little further, just giving you that heads up. Quite a few little questions around that. So from Charles and from Zara. Adrian, there's a comment here which I'll read to you because I think it goes to the heart of your article. And if you haven't read the article, for those who are joining us, just Google Adrian Plaskett. And it's the title of it, it's The Guardian, it's online, and it's something like, it's rare to be able to tell the truth, here's what's wrong with the mental health system. So you'll be able to find it. But Margaret has written, my son has chronic schizophrenia. I'm on a pension and my son is on DSP, disability support pension. He has had difficulty finding a psychiatrist in the public health system who would sit and listen to his needs. After no update on his medications for over 12 months, I now access a private psychiatrist at $200 for 30 minutes, hard on a limited budget, but at least he's getting proper care. And I just want to really give a cheer and an acknowledgement to carers who are joining us tonight and supporting their loved ones and their friends, because they often carry the load as the person that they're supporting does too, to get the help that they need. So your thoughts on that, because I think Margaret raises the issue of public health system availability of psychiatrists and affordability. And a big issue for you, Adrian, is equitable access to the support that people need when they need it.
Yeah, that's right. So I think in general, the medical system does not fund thoughtful medicine very well compared to procedures. You know, we see that in psychiatry. I was looking at the statistics. A surgeon on average makes, I think it's $400,000 a year, a specialist $300,000, and a psychiatrist $200,000. It's all a lot of money, you know, but you know, when you're thinking about what sort of profession you're going to do, if you're going to do psychiatry, you're going to take a pay cut. In my own work, the way to make money is to see people quickly and to do skin procedures. This is why there are, you know, 100 GP skin cancer places around, because you can see people quickly and make a lot of money quickly. So, you know, the whole structure of Medicare is it's kind of warped towards procedures and seeing people quickly. So that you know, kind of mitigates against the sort of work that people with schizophrenia, you know, need, which is, you know, time intensive. When I wrote that article, I had a few psychiatrists write to me, and they said, you know, when they were working in the public system, they always felt that they were doing a half-assed job. You know, they're so busy, so much stress, so worried. At least when you go into private practice, yes, you have to charge people, but you do it properly. And indeed, I think GPs who don't bulk bill would also say that, you know, why don't you bulk bill? Well, it's not because we want to rip people off, it's because I can only do quality work if I don't bulk bill, you know. Now, you can argue that from various different points of view. Personally, I find it hard to say, you know, I'm earning $1,000 a day and I can't afford to bulk bill you because you're unsettledly getting $40 a day. That sticks in my craw, but that's not because I'm, I don't know, better than anybody. That's just the worldview I have. Most people would say maximising your income is a valid and useful thing to do. So I really think you have to accept that's what people do. People maximise their income, and if you want GPs to open mental health clinics, then you want to pay them for the same amount of money as you would for doing skin work.
So Judy has written here, Adrian, I speak as the chair of a carer support group. In response to Adrian, money is no guarantee. Several of our group in Metro Melbourne have had great difficulty in finding a psychiatrist willing to manage the serious mental health issues such as schizophrenia, borderline personality disorder, bipolar. My experience is phoning around 15 recommended psychiatrists, all happy to deal with the quote unquote walking unwell.
Yes.
So, you know.
Yeah. And I think, I mean, maybe we need to rethink a little bit. I mean, this is way out of my lane, Ruths, psychiatry training. Like, you know, I could use a psychiatry registrar in my practice. I was just looking today, in the last 5 days, I've seen 240 patients. And of those, 66 had a diagnosis of depression, you know. So we would love a psychiatry registrar.
So can I butt in?
Yeah, sure.
So I mean, Adrian's bringing up another really good problem. When you do an undergraduate medical degree, you know, you get exposed to lots and lots of things. You might get maybe 8 weeks of exposure to mental health, and mostly that's going to be exposure in a hospital setting at the acute and severe end. So the sort of training that GPs get in management of mental health is actually not that good. And many do further training and go to webinars and, you know, bulk themselves up because they're interested in it. But I think one of the other things I do just have to highlight is one of the things that was mentioned in the federal budget this year was working up at least the possibility of a diploma in mental health or psychiatry for general practitioners, because there are a number of GPs who have a real interest and real skills. And as Adrian said, they're not remunerated, and technicians, you know, a GP specialist in anaesthesia or obstetrics is very differently rewarded than the GP specialist in mental health. And so we've got some real workforce things to do. But the other thing I just have to chip in, Natasha, is one of the differences, or one of the reasons I love working in mental health is it's very multidisciplinary. Grace mentioned psychosocial supports, but, you know, it means you do work very closely with mental health nurses, with OTs, with social workers, with people who deliver psychosocial supports in the community. And so I wouldn't want you to think it's just psychiatrists. I mean, I think psychiatrists are great. You know, I'm one of them.
No.
But the workforce in mental health is a really broad church, and peer support workers are part of that. But we really need to be encouraging, not just through remuneration, but also through your experience of training, your experience of work, so that people want to work in that area. And I think Adrian's point about having rotations or placements in primary care is a good one. We're certainly looking at that in headspace settings for students and trainees, and because you want people to have a good experience so they want to go into that area of work.
And that responds to David Curtin's message here. The first port of call for most is the GP. What assistance can be provided to GPs and patients to make the process work better? There's other layers to that. We might come back to that. But also, and thank you for all your questions. They are pouring in, and I'm madly trying to keep up with them. But one of them that came in, which I'd really love your response, is, well, why do we think that GPs are the most important approach, or even psychiatry? What about other models like open dialogue approaches as well? Ruth, perhaps talk to that briefly, because it's also about challenging the paradigm, isn't it? This is about not just going, well, we're going to provide more services or more support for people or more peer workers. It's also about fundamentally rethinking and challenging the way things have always been done.
That's true. I mean, mind you, I think we have the whole notion of personal recovery and in maximising people's sense of agency and choice, which has really been around now for a decade and a half or more. So I think we're on that journey.
But also the involvement of carer and consumers early on, because Margaret's written here, they're often only included in the process of developing services as token. No involvement in the co-design of services, lack of people with lived experience involved.
Well, look, I would, Margaret, go read the Victorian Royal Commission, because everywhere through that it says lived experience, we need to do co-design, we need to have engagement at the table. And I think the Victorian government is certainly working in that direction, but I think that's across the country as well. But also you mentioned open dialogue, and there is, for me, it's absolutely important that a person who is experiencing mental illness should have the same access to expert treatment, to evidence-based treatment as anyone presenting with any physical illness. So I don't want to in any way diminish the need for expertise and evidence, but I think what you're highlighting is that for many people, alongside that, being able to form groups or have access to like minds or have access to different sort of avenues of support is really important. And we've seen a lot of that through COVID as well, with the materials on Head to Health or the e-chat rooms with Headspace, and so you're right, we need to have that range, but I do not want to diminish the importance of really, really strong healthcare. Adrian, in his article, highlighted that there are socioeconomic determinants, that housing and employment and engagement with the justice system are all really, really critical factors for people experiencing mental ill health, and we often need to look beyond health. But that doesn't mean we shouldn't also look at health. Nicole's written,
absolutely. I had to sell wedding rings, furniture, etc., to pay for my son's psychiatry bills. So, yeah, big issue. Can I circle back to Grace? I'll come back to you, Adrian. But Grace, hold that thought, Adrian, because I'd love to hear it. But Grace, we had a number of questions around non-clinical support. But you also felt you had a real need for clinical support, didn't you? So I'm interested in what non-clinical support made a difference for you at the time that it did.
Sure. So there's a few things that have helped me. I think what I was talking about before was a youth residential recovery service that I was staying at that provided non-clinical support. That was really amazing, but there are some others that are really good. After I left that service, I continued to have outreach. That was changed once NDIS was rolled out, but I guess still continues in a different form on NDIS. So just, so I guess that's psychosocial support, either through like community organizations or through the NDIS, but also peer work and peer support. I'm a big advocate for that. That was at the youth resi that I was at. That's been at other services that I've used. And my favourite, which is maybe less known of, is at the Safe Haven Cafe. Is anyone familiar with that?
Tell us more.
Sure. Yeah.
So that's I think it would be considered peer-led drop-in service. There's only one in Melbourne at the moment, but since the Royal Commission, there's going to be, I think, 8 in Victoria, and there's possibly some in other states. I'm not sure outside Victoria.
Tell us what it looked like and why it made a difference.
Yeah, so that's a drop-in cafe. It's a drop-in cafe. It's not super well funded, so it doesn't have big cafe vibes, but it feels a lot less clinical than any other service. And you can just go in and have a cuppa and have something to eat and have a chat with a peer worker. And that's a great alternative to, well, emergency departments, but can be like, I don't know. I know I found that a really, really good one for hard times as well. So they're probably all the examples of non-clinical services that I've used.
Yeah, and Donna says here, Safe Haven is co-designed and co-delivered. And Darren says, we have these in New South Wales. Oh, Katrina says, we've got these in New South Wales. Such a great initiative. Darren says, we just opened ours in Sydney, ! Peer-led. So that's obviously a great model. And you mentioned hospital emergency service, and I guess what comes up again and again, both for carers and families and for people who are going through some real challenges with their own mental health, emergency is often where people will naturally go because things feel urgent. And where do you go when you have an urgent health crisis? You go to emergency. Is that something that when you sit down with peers at a place like Safe Haven, is that something that people talk about?
I don't know if I've talked about it at Safe Haven, but I have talked about it in a lot of other spaces. A lot of people end up in emergency departments because there are very limited crisis supports available, and that's one of the few. And I think they're harmful at best and often far worse than harmful. They're not great places to be when you're in a mental health crisis.
Yeah, and it's a blunt instrument, isn't it, in a way? And then what kind of follow-up do people have? Adrian, people do front up to emergency, and then I imagine you probably sometimes are then connected with them in the fallout of having gone to an emergency department. And what people often talk about and have told me is that there isn't necessarily follow-up after emergency. There's no, if you go to emergency and you're in a really severe state, you don't necessarily get a call later to check in on you.
No, I think, they are trying to do better at that, but yeah, it's such a broad area, and again, it's not just mental health, but I think when you work in emergency, it's such a difficult environment. It can be. I think doctors have a bad habit of when people don't get better, starting to blame them. And I think if you're someone who goes in and out of emergency, you pick up on that very quickly, and it makes you even feel more shit house. So I hope that they that we do better than that. But I don't know, Grace, was that your kind of experience, that you're wasting time and then, they're not particularly interested in you? And
I mean, my experience is mostly not being taken seriously, I guess. Like,
right.
I've gone there because that's in my safety plan, or I've gone there because that's what Lifeline's told me to do. And then I've gotten there and explained what's going on. I think with people with diagnoses around complex trauma, we're often not taken seriously. And more often than not, I'm told, my safety is my responsibility, go home. And it's just invalidating. It's stressful, like it's not a nice environment. And it just makes you feel worse than before you went in.
Yeah.
That's my experience. Yeah. Look, maybe that is just my experience. I'll say that. Yeah.
But I think it's an experience that many share. And so thanks for describing it. It's important that we do describe it, and people are. Nagar has written, emergency departments are poorly resourced. As a psychologist, I have sent my severe mental health clients to emergency, but they were discharged in a couple of hours without help or direction. And then Mary's written, there's no other way to access treatment for acute illness other than through emergency in regional Victoria.
Yeah, that's right. Yeah.
And Viv has written, emergency departments are not places for people in crisis. What's happened to our crisis mental health teams that will see people where and when needed? A 1-800 number is not sufficient. So, Ruth, that's when things become a crisis, a hospital is where we head because that's what we know to do. But it's actually, it can be more harmful.
Oh, look, and I think it's widely recognised that, again, as services became increasingly under pressure, and as I mentioned earlier, that sort of mismatch between funding growth and population growth, that one of the casualties was that the crisis outreach teams became less available. Another thing that I think has made that very difficult has been some of the changes in presentation, and I do have to say staff safety is paramount, and often, so there are some models now of clinicians going out with police or going out with ambulance to try and address those problems in the community rather than in the emergency department. There are some very good models. There's a new model in Adelaide that it sets up as an urgent care centre that is separate from the emergency department. And of course, many emergency departments are trying to design some area within them that is more welcoming and does feel safer and more containing. But I agree with the comments that have been made. I also think it's really important that if a person has a severe mental illness, they should be able to go to an emergency department and should receive the sort of treatment and intervention in a safe and caring way. And so, it should never be thought that is not an avenue. But Grace has highlighted, I think, some of the negative aspects and also some of the new models. And the other sort of, I mentioned at the beginning that we sort of recognise that there needs to be greater integration between some of the state-funded services and some of the Commonwealth-funded services. And one model of that, I think, is the proposed adult mental health centres that will be community-based, but be able to receive people in significant distress, not necessarily, bells and whistles, but significant distress, and again, provide a welcoming, containing, safe response. So I think there are lots of models, but we've got to get them well integrated, and we've got to get them well, equitably distributed across the states and country. And that does mean we need a lot of growth, and we've seen some of that in recent budgets. But it's going to take a long time, Natasha, to get this part of the health system absolutely back into a very, very highly functioning, equitable, affordable state. And
so let's focus in the last 15 minutes that we have together on where you all see really strong positives, because I'm aware, and I've been part of these conversations for a long time, and many of you have, and many of you joining us, of the many hundreds joining us, have too. Brendan acknowledges his sadness and his frustration and anger that we are still having these conversations. It's been years now. What will it take for action? So I acknowledge people's frustration, but I also want to reinforce that I think having these conversations is vital, because it also brings people into the room that might be just finding their voice for the first time and might become very powerful advocates around these, around the mental health care system in Australia. So I acknowledge everyone's frustration, but I also want to acknowledge that we won't get to all the questions tonight, but the questions will inform future events that Themes runs. They're very committed to these open dialogues, but they, as you know, are very committed to back-end reform. And so these questions and comments that you put into the portal, they will use as an ongoing resource for their own work and the conference coming up. So people are mentioning models, safe havens. Bill Guy has written safe havens, recovery colleges, the clubhouse model, open dialogue. There are a plethora of really effective models that could be funded all across Australia for less than half the funds going into better access now, and which an overwhelming body of evidence shows keeps people out of hospital. Let's look at where you see the priority should lie from your perspective as a GP, Adrian. What do you see that's happening that is positive? What do you see needing to happen as a priority?
Well, I think so. Some of those things that you mentioned, like the clubhouse models and the cafes and so on, they all have that sense of community, don't they? Where people have come together, worked out solutions, perhaps informed by expert and so on, but then as a community have moved forwards together, and I think that's a wonderful model. I'd certainly, I think some of the Aboriginal health models where you've got the health workers employed by the community rather than as a business itself, I think that's a model that really appeals to me as well. I think there's
that notion of deep listening that Aboriginal mental health services often employ, that notion of deep listening, really. And Kylie's written this too. There's a great benefit in just sitting with someone in distress. You don't need to label it or them, just the power of connection and empathy can truly change lives. There needs to be more funding and support for services like this. It's not to take away from clinical support, she says, but to complement each other.
No, that's right. And then I think also from my point of view, the understanding that such basic things as exercise and diet and so on are so profound in mental health. That can be integrated by people who don't have to be doctors and clinicians and so on. As I could see how that would fit into a clubhouse model or a community model so well. And I think there's so much hope with neuroplasticity and so on, that conditions that we used to say personality disorder, can't do anything, now we know they're all infinitely treatable, and there are very well established pathways to really make people better in ways that we used to just in a very uncomfortably dismissive way. I can't believe how they used to get talked about. So I think there is a lot of hope there, but somehow the funding needs to be allocated to the burden of illness, and I guess that requires all of us to try and advocate, doesn't it? To attend things like this, to take the courage to vote accordingly or whatever it is, so that you live in harmony with your values and try and make that sort of difference to whatever level we can. Sorry, I'm rambling a bit now.
No, you're not. And I want to throw in a really positive model, and I don't know a lot about it, but Shandy's written the Urgent Mental Health Care Centre that's recently opened in Adelaide. 50% peer workers, 50% clinical staff, a wonderful alternative to emergency departments. It's just become a 24/7 service there. So that idea of replicating good models that are happening in other states all over Australia, there's something potent about that. Grace, from your perspective, and as you empower yourself to find a voice as someone who's experienced the system, what would you like to see from your own experience more available?
Okay, there's so many things. I'll see if I can power through a couple of them. I think the first one is listening to lived experience voices. I'm seeing it happen a lot more, and it was mentioned a lot in the Royal Commission, so I have high hopes that will be centred a lot more, but there needs to be a lot of co-production. Lived experience voices need to be part of every service. And running services as well. Like I said, more like I was talking about Safe Haven, more peer-led services like that. Similarly, I think peer work is just so important. That's a growing workforce as well. And I can't wait to see a lot more peer workers and things to support them, because there's also a lot of supports missing. Two other things, I guess, that I'm really passionate about.
You can have more than two.
I'll just go with two for now. The list is infinite. Yeah, I've already spoken about them, I guess. Alternative crisis supports. Yeah, I was going through the list of them myself the other day. I'm starting to be a bit more unwell, and I was thinking, okay, what am I going to do next? And I was going through the list of crisis supports that are available, and I don't want to use any of them. So I'm a big advocate for for alternative crisis supports. And then just generally more, I spoke earlier about the missing middle. I think that's another one that I want to see addressed. Yeah.
Fantastic list. Just give me a more of a sense, give us all a little bit more of a sense of what you mean by the missing middle. I know you articulated that earlier, but I think it's a vital one, because someone else has made the point too. It seems to, you know, the mental health system sort of seems to operate between those that might benefit from 6 psychological sessions and those who are in extreme need. And then there's this whole
So
burden of need.
I see it as kind of like the gap between early intervention services, or people who like maybe 10 sessions is enough for, and then the other end of like your adult mental, well, I guess youth as well, but your local community mental health service that is like case managed, might have public psych admissions, and you kind of have to be really, really unwell to access those, but on the other end quite well, I guess. I don't like using that language, but that's kind of what, I get it, where it forces you. And anyone that's in the middle, there's either you can't access them because you're not eligible, or neither is adequate. So I guess addressing that.
Yeah. And I think it's a really vital point you raise around language, because people, you know, self-categorize, but everyone has needs and they need addressing in order to fully flourish. And so that's really vital. I'm throwing into the mix here from Kath. She's written, another important peer support-led service is alternatives to suicide. It's a peer-based response to supporting people who have experienced suicidal crisis or suicidal thoughts. It's the Alternatives to Suicide in New South Wales project is working to make these groups available across New South Wales. Similar work happening in WA and some other states. Fantastic. Thanks for sharing that, Kath. Yeah, go.
I can briefly add to that. There's the WA one, I believe, is called Discharge and sounds amazing. And there's a Victoria one called, I think it's specific for LGBTQIA+ folk, but called Aftercare, but I'm not sure if it has funding at the minute. So yeah, they are great ones that I have heard of as well that I forgot to mention before. Yeah.
Emma's written, we are now rolling out assertive outreach services from hospital emergency department referrals in Victoria called HOPE, which stands for Hospital Outreach Post-Suicidal Engagement. And that sounds phenomenal and so vital, because what a lonely experience to front up to emergency and then be ejected out of the system, denigrated, shamed, embarrassed, whatever you might be feeling, and not heard in that heated environment of an emergency department. Ruth, Lee, I think, wrote, Ruth, what you are saying is giving me hope.
Thanks, Lee.
That's lovely feedback, isn't it?
And just to add to the other hope you just mentioned, I mean, we haven't actually touched on care of people who are experiencing suicidality or even families who've experienced that tragic sort of bereavement. But in fact, one of the expectations is that sort of service will be made universal. And it's as that person highlighted, they're rolling it out in Victoria, but in fact, some form of support to people who do present in that sort of suicidal crisis is going to be universal, and I think that's great. But Natasha, I do have to say, and I know we're about to run out.
And in fact they've said that we can finish it at 10 past, so we'll do that. We'll take that extra 10 minutes, and hopefully many of you can stay online with us for a few more minutes, and I'll try and get more of your questions in.
Okay, I'm not, that's lovely. I guess I was just going to say the list is clearly long of what needs to be, what could be done, and it needs to, I guess we also haven't mentioned the sort of age range. And again, one of the things that COVID has thrown up has been a lot of increased uncertainty and distress in younger people. And so we need to sort of remember that we do need responses for young adults as well as, of course, older Australians, and then looking at the system and the system between primary care, which is where Adrian sits, but right into some of that more assertive care, and then the availability when needed of inpatient care and aftercare. So I that's, to come back to my original points, I think that's where it's so important that the Commonwealth Government and the states and territories work together, because they both have responsibilities across those dimensions. And at the moment, in some places, we duplicate even. We're just not well integrated and don't have the service system really sorted. But I think the Productivity Commission highlighted a lot of that. The Victorian Royal Commission did. My other shout out would be workforce, and I accept Grace's encouragement of the peer workforce, but I absolutely think that we need more psychiatrists, better distributed psychiatrists, more affordable psychiatrists, as well as mental health nurses and allied health and psychologists. So,
but alongside that,
plenty of work to be done.
Kate's written somewhere to go, something to do, someone to talk to. A very simple model for connection.
Yeah.
Back to you, Adrian, because in the Guardian article, you list some really potent solutions, very sensible solutions. And one of them, though, which is provocative, target mental health services to those who have severe illness. This means the free state-based mental health services, rather than funding private psychologists to deal with mild to moderate illness in the wealthy parts of major cities. That's a direct quote. You were stating your case. So now this is vital, because what you're getting at there is, okay, if we've got limited resources, where are the needs most? I mean, I would argue that the needs are most everywhere in relation to mental health.
Indeed, that's right.
And that we shouldn't undermine, everyone needs support, regardless of their circumstance.
Yeah, I mean, health in general is a difficult area, in that we can spend an infinite amount of money on any one person, and they still get sick and die in the end. And so there always is a rationing and allocation of resources that has to occur. I mean, I'm a big fan of sort of looking at the system. So rather than saying, what are the words of the system? If you pick up the phone and they say your call is important to you, my call is important to you, but you don't feel important, then your call is actually not very important to them. Your money might be, but how they treat you is not. So if you look at a system and stand back and say, who is this system serving? Then you realize how the unconscious design has appeared. And I see this in society in so many areas, whether it be education or health, or indeed even the vaccine. I imagine every doctor and their family has probably got 90% vaccination rate, whereas the Aboriginal kids out at Wilcannia are not even on the list yet. I mean, kids aren't qualifying yet, but you get my drift. I think we pay a lot of lip service to equality and equal access and this, that, and the other. And yet, if you look at what are the outcomes, they don't fit with that. So, and I think we have to be really quite explicit about that we don't necessarily need a system that's equal if our outcome is equality. We need it to be targeted. And I don't think that's something that the government talks about that much anymore. It's all about flat taxes and everybody having a equal playing field. Well, not everyone gets a kidney transplant, only people who need it.
That's vital, and it applies to education, it applies to so many things.
And what I see is sort of this intergenerational, I don't know if it's really diagnosable mental illness, but I mentioned just sort of children and so on. You just see the kids coming in and they come from a difficult background, and the parents don't have a lot of they haven't learned themselves much in the way of parenting. Not that I'm any expert. I mean, we've had kids off to the psychologists and psychiatrists, just like everybody else. If there's no mental illness in your family, then you're just not looking hard enough, I think, because it's so common. But what I mean is, you can just see that this whole situation is leading to a perpetuation of the cycle through no individual's fault. And I would just love
so this is you're gone.
So I'd just love to see the system more explicitly targeted at that, without being, patronising. It's not for me to tell. I guess that's where the peers come in, maybe, because I don't know. Again,
but it's also as you point out in your article, it's about, and Ruth has made this point strongly too, about connecting dots, connecting. So early intervention, early support. So, as you point out, you want good quality parenting support and childcare to the very young, so it's sort of early on, well-funded public housing, the power of stable housing.
Yeah, that's right.
Early
I think
in your
one of the
life.
biggest interventions could be just giving people housing. That it'd be interesting to see if there are statistics. I mean, my wife's a housing researcher; she'd be able to help. But maybe it's more important to spend money on public housing than it is on some aspects of the mental health system. But it's
the power of a roof,
silo, isn't it?
Yeah, that's right. And raise job seeker. Many people who had job keeper and more money, more basic money to pay basic bills and get vegetables.
Yeah, I mean, you can't live on $40 a day. That's going.
You cannot.
That would make me fall to pieces. That feeling of not being able to support your family and just meet basic needs. I mean, it'd be awful. Absolutely.
But that bigger story of that it's all stitched together, the social, the psychological, it's all connected.
And with this pandemic, everyone's clear cut, external force causing mental health problems. But we don't take the same approach when someone loses their job from, economic rationalism or whatever, So yeah, you're in the pandemic, you need money because otherwise you're going to have mental health problems. But you've lost your job, you're a job snob. Sorry, it's just such a double standard.
Let me come back to Ruth in your role, how you see those conversations happening, because you're sitting there with a mental health hat on. But do you feel that you can actively get the systems talking to each other across the silos? Housing, job keeper, job seeker, mental health services, early childhood support, schools.
Well, I mean, of course, these things are complicated, aren't they? And there's always tensions in each of those portfolios. Should single mothers of children be given priority housing over a 40-year-old man with severe schizophrenia? How do you make your choices? But I absolutely do think that we have a really good understanding of the socioeconomic determinants of mental health and ill health, and also of the importance of, and Grace touched on this, on the importance of broad support. So if you look at some of the avenues for support through NDIS, some of those are about supported independent living, sort of illustrating that a person with significant disability because of mental illness needs somewhere safe to live and a degree of psychosocial support that goes with it, if that's their level of need. So, but I guess one of the answers that I was thinking of, Natasha, as Adrian was talking, was, how fantastic it is that we pay taxes, because that's what our taxes do. They provide good public services, and we should all love paying tax, because it's what generates these safety blankets, these safety sort of nets that we have. The other thing the other sort of thing I think we perhaps haven't touched on this evening, but I think is really important, is many people, when they struggle to cope, develop drug and alcohol problems. And we haven't really touched on the importance of good access to drug and alcohol services. And it is another problem within Australia's landscape that has not been well integrated and not been well serviced, I guess. If you look at stigma and discrimination mental health sort of down there somewhere, but drug and alcohol problems are as well. And really recognising that people need proper wraparound supports, including that you highlighted, financial and housing and family, and particularly in this COVID context, again, it's families, families who are really struggling, who are having to homeschool their kids and struggle with employment, and really highlighting the supports for parents. So the list of where to provide supports is very long, but at base we really need a good mental health system, and that's across primary, secondary and tertiary, and with good accessibility.
We really need it. We don't, it's not a case of should, as Stephanie's written, should, have to get it right, won't get us anywhere. She's calling for Grace and Adrian to keep fighting the good fight. She was a carer advocate and it really burnt her out. So we have to be really building that next generation of advocates and activists on this issue as well, for all of our benefit. I'm really grateful to all of you for your questions, which are just pouring in, really engaged. I love doing themes events and discussions because of this, because you are all so vocal and so articulate on your needs through, the brute force of experience, I guess. So thank you very much for all your comments coming in tonight, and they will be saved and used as a resource to inform further discussions, and perhaps drug and alcohol might be one that we pick up on again. I want to acknowledge, we're about to wrap. I would say if you're really itching to say something to wrap, Grace or Adrian, I can allow another little comment, but shall we wrap? Fantastic. I want to acknowledge Grace, Adrian and Ruth, terrific speakers. I can see that a lot of you have really connected with what you've been saying tonight. Let's continue the conversation, everyone. I want to also mention the TheMHS annual conference coming up on the 12th to the 15th of October. It's all digital. So wherever you're joining us from across the country, in New Zealand or beyond tonight, you can also come along to the conference, the virtual conference again this year, given the pandemic. The theme this year is Hope into Action. People at the centre, people, let's just pause on that, people at the centre of mental health system reform and design. You can find all the details of the conference on the TheMHS website. Let's give a virtual round of applause to Grace, Adrian and Ruth, and to all of you for giving us your hour tonight. I'm Natasha Mitchell. Thank you so much. I look forward to the next conversation.
Thank you.
Thank you. Bye-bye.